moving on to another type of complication that has to do specifically with upper molar extraction, sometimes upper premolars, where the roots are close to the sinus. Oh my God. Well, that's where the sinus is anatomically. So it's not surprising that when you have a periapical infection, once you extract the tooth, the sinus is going to say hello, okay? And you're going to say hello back in the form of treatment. So there are two types of sinus communications after an extraction. One is a large opening, like huge, like almost like the same diameter of the tooth, and it happens. I'll show you an example. And sometimes it's small, like a pinpoint, a tiny little, like the mesiobuccal root is communicating, but all the other roots are okay. All the other sockets are fine. And the management is different. For the large openings, obviously, we're not talking about immediate placement in these situations. It's just contraindicated. But for a large opening, well, you can't really graft that well. The focus is not the bone graft. The focus is the closure. Because if that thing stays open, the patient is going to have an oroantral communication or oroantral fistula. Not a fun thing if it stays open. I'll show you how to manage that as well. Because if it's open from the extraction socket, there's an opening to the sinus, and the sinus is connected to the nose. So patient is going to drink a cup of water. The water is going to go in the socket. It's going to go in the sinus. It's going to come out the nose. And the patient is going to eat some rice. And that rice is going to be shoved into the sinus. And that rice is going to maybe come out the nose as well, if it's going to pass the middle meatus, which is the communication to the nose. So a sinus communication could be a serious complication if it's not managed properly. So I wanted to empower dentists that are doing these types of extractions. You are acting as an ear, nose, and throat, as an ENT or an otolaryngologist. You're doing the patient a big medical favor. These types of infections infect the sinus. You're extracting a tooth. You can pretty commonly see a lot of suppuration coming out of the sinus. Well, take your suction, stick it in there, suction all of this out. Don't be scared of it. You're doing the patient a huge favor. They're going to feel way, way better. And they will tell you that they've been dealing with their sinuses for so long, and you saved their lives, so to speak. You saved their sinuses. What's important in those big communication is not, it's not going to help to saline irrigate. It's to mostly suction it, but it's important to create some closure. And when you have these big infections on upper molars, the tissue, there's so much bone loss, the tissue is kind of loose. It's not that difficult to close. If you need to advance tissue or you need to undermine the tissue, just do that and create good closure with continuous interlocking gut sutures. And the thing is going to close up on you, and your patient is going to be well served. What to do with implants later on? Well, you're not going to have a great site for an implant because the sinus is going to be with no floor. So forget about placing an implant. They'll need to be augmented and reconstructed. And, we deal with this with our other courses. I'm not going to focus on this right now. But that was a big opening. But if you have a small opening, like a small communication, don't freak out. First thing, diagnose. Look at it. You don't have to have the patient blow their nose and damage the membrane further. You don't have to. This is only when you have a doubt that there's a communication. But if you can see it, it's obviously that hole is the sinus saying hello to us. The sinus is communicated. So not to worry too much. Use something called the sandwich technique. What is the sandwich technique? It's like a sandwich. You have a deep layer closer to the sinus where we use collagen. We have a middle layer with bone, and we have a top layer that is sealing the socket, again, with collagen. That's the bone sandwich. Okay, so here's an example. A tooth that is fully decayed is extracted. This is not pinpoint, but it's not the biggest opening that I've ever seen. You can see the sinus membrane very clearly. You see the opening. You see that I was able to preserve some of the interseptal bone. So I'm going to use the sandwich technique. The deep layer, you can use a collagen plug. Here I'm using actually gel foam, but it's also part of the sandwich. Then the middle layer is a bone graft. Don't condense with pressure, obviously. You're going to push it into the sinus. So very light packing. And then the top layer to close up the sandwich is again a layer of collagen and close it up. You don't need primary closure. These things heal very, very well. I don't want to say 9 out of 10. It's probably, I don't know, like 90 out of, like kind of very high percentage, like 99%, it's going to close by itself. Extraction, you identified a pinpoint, you're going to sandwich it. Remember the sandwich. Collagen at the bottom, bone in the middle, collagen at the top, closure, and you're going to get a nice closure, and then you can later on go back and maybe even do a sinus lift or place implants if you don't need it. We have a decent site for an implant. Now, what to do with big communications, okay? Big communications, the sandwich is going to fall into the sinus. Here's an example. The patient has a large periapical lesion. Here's the cross-section of a CT scan. That's ginormous. This is very, very big. So I'm going to think not so much about sandwiching. I'm going to think more about I need to have closure. So here's the extraction. There's a big opening into the sinus. So we call this a double layer closure. First of all, from the buccal. So I make 2 vertical releasing incisions. Okay, I don't love verticals, but you need to have verticals here. So 2 verticals on the line angles of the adjacent teeth. Make sure that you advance it in a split thickness flap, and we teach this in our courses to make sure that you know how to advance tissue without tension. So that's one part of the procedure. You advance it, but the second part is to create a pedicle from the palate. Again, this is taught in our advanced courses, and if you doing a lot of extractions, make sure that you know how to manage them using a pedicle. So I'm going to split the palatal flap in half and take a pedicle from the palate that is still attached, rotate it on top of the socket, and I'm going to close it up. And here I'm suturing the pedicle actually to the bone. If the bone is thin, you can actually pass the needle through it. So this is the first layer right on top, and the second layer comes from the buccal. We're going to close it, and it needs to be closed primarily. And I know that I'm going to have some mucogingival issues here. I'm going to have some mucosa on top of the ridge, and I'm going to fix this at the time of placement. But for these types of openings, don't mess around. Try to close it up primarily. Gore-Tex is a very important suture material. This is a horizontal mattress technique. Closure, of course, you have to close up those verticals, and it's going to close up. And I actually got some bone to place an implant and was able to manage that because the membrane for this patient was intact. So my bone graft did not go all the way into the sinus, and we got this case handled. Now, what if it doesn't work out? What if we have still an opening into the sinus, like after this extraction? You can try and close it. But if you try and close it and there's still infection in the sinus, still some food, well, it's not going to close. So what you need to do here, something very simple that every dentist can do in their office. Okay, it's simple. You need to create an obturator. So carefully, you take an impression. Optical impression is obviously preferred because you don't want impression material in the sinus. So you can put some aluminum foil on top of the ridge, take an impression, get your suck down working. Simple. Take that suck down, deliver the suck down in the patient's mouth. They need to wear it all the time. And that will stop the impaction of food. And all of a sudden, you're going to see that communication starting to close up. You see it's starting to granulate in, but because of the large opening, the food and liquids going in there is going to impinge on the healing. So if you deliver that obturator, it's going to start closing. And I let them wear the obturator for days, for weeks, for months, until I see that that hole is getting smaller significantly every time. And then if you needed to still do a closure, it's way simple to do a tiny little pinpoint closure, or it's going to granulate from within. To do an implant in these situations is a completely different ballgame. I actually recommended a 3-unit bridge because I didn't want to involve the patient with another opening of the sinus. But this case resolved very well, and you have now a system to manage these openings if the openings persist. Okay, here's a cracked upper molar. You can see the crack in the middle of the tooth. One cusp broke. It's already perforating into the sinus. That hole in there, that's the opening to the sinus. So not a big opening, but enough for me to diagnose and use the sandwich technique, that bottom layer of collagen, that middle layer of bone, and the top layer of collagen, or PRF plug, that's the top layer in this case, and sandwich technique is done. But this case did not work out. Whether the patient was blowing their nose or just, it did not work out. Remember, it's your job to perform, to do the work. And that's what I did here. And I followed my own teachings. But it's the patient's job to heal. I can't take responsibility for that. Okay, I can give them good instructions, but if they're going to blow their nose or they're just not great healers, that's what's going to happen. And I need to manage. How do we manage? Some aluminum foil, impressions, a suck down obturator. Obturator is a fancy word from the maxillofacial prosthetics for cancer patients, but we use it also for sinus communication. The patient is going to wear this obturator as much as possible, sleep with it, eat with it, so no food gets impacted. And not surprisingly, that's going to allow the granulation tissue to slowly close up because it's not interfered, and it's going to close up until complete closure. And it's a great thing to see this time after time again, because having extracted thousands and thousands of teeth over the years, many of them molars, many with sinus communication, and some had this persistence, the obturator is the way to go. It's cheap and simple, and every dentist can do this.